Charles, thank you very much for the invitation to take part in this symposium. I think I'm going to try and speak a bit slower to deal with the echo. So yes, my focus is really going to be the etiology of neuropathic pain in the context of diabetic neuropathy. Painful diabetic neuropathy is a common problem within the context of diabetes. So some fairly large epidemiological studies in the UK, for instance, have shown that around about 30% of subjects with diabetes will develop painful diabetic neuropathy. And it's interesting that if you look at all of those patients with neuropathy, it's around about 30 to 50% that will go on to develop disabling neuropathic pain. And of course that begs the interesting question, what is special about those patients that go on to develop pain as a complication of diabetic neuropathy? And it should be said as well that that pain is actually a very complex subjective phenomenon. So of course there's many different ways that patients may use to describe pain as to whether it's like pricking needles or electric shock-like sensations. And of course we're using that variation as a means to try and stratify patients. And Ralph Baron gave a nice description this morning about using mapping different complexes of sensory symptoms and sensory signs potentially to mechanisms. We've taken what you could call quite a simple approach to try and get some kind of handle of neuropathic pain in the context of diabetes, and that's to take a cohort of patients with diabetic neuropathy and to compare those patients that have developed neuropathic pain to those patients that haven't, and see how we can stratify patients, and then in a very detailed manner try and understand the sensory function in those patients and relate it to the severity of their neuropathy and neuropathy outcomes, and also to then take subsets of patients and trying to look at the influence of genetic factors and, for instance, to apply modern functional imaging to this question, comparing those patients with neuropathic pain to those without. So we did this as part of a study which we called the Pain in Peripheral Neuropathy study, and this was a collaborative study between myself and other investigators were Andrew Rice at Imperial and Solomon Tesfaye in Sheffield in the UK. And actually we recruited patients from multiple sources, so we didn't just recruit them from hospital, we also recruited them from primary care because we wanted as representative picture of diabetic neuropathy as possible. And I'm not going to go into the details of how you diagnose diabetic neuropathy because that's going to be covered in a subsequent talk. But essentially we wanted really quite a firm definition of diabetic neuropathy. They had to have clinical signs of neuropathy and there had to be an objective measure of diabetic neuropathy, whether that was a reduced nerve fiber density in the skin or nerve conduction studies. We then undertook detailed phenotyping of their pain symptomatology. We're using a number of questionnaires, and really to define neuropathic pain we used the NOIPSIG grading system published in 2008. So we used a very firm diagnosis of neuropathic pain when we were saying that they definitely had neuropathic pain. We also used a measure of the intensity of that pain using a pain diary, and we stratified patients in that way. And as you can see, we ended up simplistically with three groups. There was one group that had diabetic neuropathy and no neuropathic pain. There was another group that we defined as having diabetic neuropathy and mild neuropathic pain, and they had a numerical rating scale mean score of up to 4. And we had another group which we defined as moderate to severe neuropathic pain, where their numerical rating scale was between 4 and 10. And it's a slight arbitrary cutoff between the mild and the moderate group, and really we just took that because often in clinical trials, to enter that trial, patients need to have a mean numerical rating scale pain score of greater than 4. So just to look at the distribution of the pain in these different groups, one thing to say is that those patients that didn't have neuropathic pain, they actually had lots of other types of pain. So actually it was very common for patients to report pain in their lumbar spine or in their shoulders, and really that speaks to the fact that when it comes to clinical trials, we need to be very careful on our phenotyping, because unless we are looking very specifically at the neuropathic pain, all these other musculoskeletal pains that they're suffering could definitely confound our outcome measures. Those with mild neuropathic pain, well actually we're now seeing the classic distribution of pain in diabetic neuropathy with particular emphasis on the feet, and some patients also reporting pain in their hands. And when it comes to those groups with moderate to severe neuropathic pain, again, predominance in their feet, actually we're seeing more involvement, a significantly greater distribution of the pain, particularly in the hands, in those patients. And we also looked at some of the scores, some of the screening tools that you would use potentially in clinic to look for neuropathic pain. So one that we used, for instance, was the DN4, Dolor Neuropathic 4, and we benchmarked how did that perform against our gold standard definition of neuropathic pain, and actually it performed very well. So in fact the sensitivity was 88% and a specificity of 95%. So I can say in clinical practice in a real-world cohort of patients with painful diabetic neuropathy, this is a nice screening tool for neuropathic pain. And you will see as you go up in pain level, the neuropathic pain symptom inventory score goes up, as does the pain interference score. And one fairly simple thing we did, but I think it's important, is to say how can we relate the presence of neuropathic pain to the severity of someone's neuropathy. And actually we found a significant correlation. The more severe the pain was, the higher, using a clinical score, the Toronto Clinical Severity Score of neuropathy severity, the higher that the severity of the neuropathy was. So there's been some anecdotal tales of could it be that as patients' neuropathy gets worse, eventually they lose all their nerve fibers and they no longer experience pain. That certainly wasn't the case in our cohort. Those patients with a more severe neuropathy also had more severe pain. We used some objective measures in this study, and one was skin biopsy taken from just above the the lateral malleolus, and it's a small punch biopsy, and we can actually see nerve fibers, and we've got a comparison here in red of the nerve fibers crossing the epidermal junction, and the effect of diabetes, as I said, we know it's a diabetic neuropathy, that you lose these nerve fibers. In fact, interestingly, when we quantified that, we didn't find a difference although we saw a big difference to control diabetic patients that didn't have neuropathy, all of those groups with neuropathy, whether they had neuropathic pain or not, had a marked reduction in their intraepidermal nerve fiber density. We didn't see a relationship between the degree of that reduction and their pain severity, although I think one of the issues here is we probably have a flooring effect because we've got such a reduction. In fact, to really study this problem, it would have been useful to look at a more proximal site where the denervation was less severe. So one of the things Ralph Barron spoke about this morning was using quantitative sensory testing to give a range of sensory stimuli, as it were, to test the sensory system to give us potentially some insight into pathophysiology. So as he described, we used the protocol of the German Neuropathic Pain Consortium and giving a number of different sensory stimuli and looking at thresholds and stimulus response function. And in doing this, we could then compare these different groups of patients. So I have to say that the predominant finding, as you may have guessed, in diabetic neuropathy is a loss of function. So just to describe this graph, we generate the data into a Z-score, so the individual patient's data is compared to a very large normative data set, and we've got different groups of patients here. In blue are those patients that have neuropathy but no neuropathic pain, yellow they have mild neuropathic pain, and pink moderate to severe neuropathic pain. And these are now looking at thermal parameters, so whether it's looking at warm detection, cool detection, cold pain threshold, and heat pain threshold. And what you can see is actually a marked loss of function. There is, if you look at the whole population, more loss of function in those patients with the moderate to severe neuropathic pain. And actually, if you think about it, that's consistent with the fact that these groups of patients have a more severe neuropathy. When we come to mechanical thresholds, and again, either giving low threshold mechanical stimuli, such as mechanical detection threshold used measured with applying a von Frey hair, we can see again there was a loss of function compared to normative controls, and in fact that loss of function is more marked in those patients with a moderate to severe neuropathic pain. Interestingly, that isn't true across the board. So if you look at this graph, PPT stands for pressure pain threshold, which is applying an algometer, and really you're looking at the response to stimulation of deep tissues. And in fact, the pressure pain threshold was well maintained in all of these groups. which I think is an interesting finding and may imply that we're getting less injury to those deep tissues as compared to more superficial tissues. Another interpretation would be that there's some sensitization within those deep tissues. We can also look at some special phenomena, I will call them. So one is paradoxical heat, which is an interesting phenomenon whereby if you apply a cooling stimulus, some patients will report that actually they feel that as warming. And it has been at times described as a positive sensory phenomenon. Actually, I would argue that really it just shows sensory dysfunction. And if we look at the instance of reported paradoxical heat sensation, and we compare those patients with diabetic neuropathy with no pain and those with no neuropathic pain and those with neuropathic pain, paradoxical heat sensation is actually very common, but it's not different between these groups. So I really think that's just a representation of the fact that you're losing afferent fibers which mediate thermoception, and that's confusing your interpretation of that information within the central nervous system. It's not saying anything specific about pain per se. Allodynia, whereby, for instance, brushing the skin can evoke perception of pain, so a non-noxious stimuli resulting in pain, was the one finding that was absolutely specific to those patients that had diabetic neuropathy and neuropathic pain. But I have to say it's not a common phenomenon. It's really only seen in around 15% of those patients with neuropathic pain. And really that would imply in this subgroup of patients that there's likely to be some kind of central sensitization within the nervous system contributing to their neuropathic pain. That may be a challenge when it comes to substratifying patients. So again, one of the discussions this morning was that could we take a group of patients with the irritable nociceptor phenotype, and then they may be more responsive to certain agents such as oxcarbazepine. That irritable nociceptor group would only form about 6% of our cohort with painful diabetic neuropathy. So in this particular context, this etiology of neuropathic pain, it's not a common finding. I just want to touch on the fact of the genetics of pain and how that may relate to painful diabetic neuropathy. So, interestingly, in the last 10 years, we're really seeing a huge evolution in the field, whereby we're understanding that there's certain rare Mendelian pain conditions, and we're understanding the genetic basis of that. So just to give an example, this is a patient of mine that has a condition of erythromelalgia, which results in very painful red extremities, and it's an episodic condition, and it's autosomal dominant, and a number of members of her family are affected. And when you looked at the genetics of this, she in fact has a mutation in an ion channel called NAB1.7, and that's her mutation shown there in red. And what this mutation does is it results in this ion channel is more likely to activate, and that increased activation of this ion channel leads to hyperexcitability of primary sensory neurons. And in fact, as time has evolved, we now know that there's a huge number of different mutations in this ion channel that can result in erythromelalgia. So this is a nice example where a single base change in a gene encoding an ion channel can give rise to a Mendelian pain disorder. So one question is, if we take our cohort of patients with painful diabetic neuropathy, do we ever find mutations in voltage-gated sodium channels? And actually the answer is yes, but they're not common. For instance, I'm showing here a number of different mutations. Some of them have previously been associated with erythromelalgia, some of them have previously been associated with small fibre neuropathy, but for our whole cohort of painful diabetic neuropathy, we're talking less than 5% of patients. One question would be that might have clinical relevance, particularly with the evolution where we're trying to develop more specific blockers of sodium channels. So can we identify those patients that have these rare high-impact mutations in voltage-gated sodium channels? Would there be something in the phenotype? And unfortunately, so far, no. So this would be the mean QST profile, quantitative sensory testing profile of the population as a whole. And these are those small group of patients that have mutations in NAB1.7. And looking at this profile, it is no different. And if you were to look at their pain symptomatology, it wouldn't be any different either. So this is going to be a challenge as to how we may develop personalised medicine to this small cohort of patients. Now, traditionally, my interest has really been the peripheral nervous system, but I have to accept the fact that ultimately pain is perceived in the brain. I can't get away from that fact. And in Oxford, I'm lucky enough to have a great colleague in Irene Tracy. And so what we did is we took a subset of these patients and said, well, actually one thing we could do is compare the structural and the functional brain imaging in those patients that have diabetic neuropathy with neuropathic pain, and very closely case control matched patients that have diabetic neuropathy but no neuropathic pain. How sensitive are these imaging protocols? Can we stratify patients in this manner? And the answer is yes. So if we were to compare using a technique called arterial spin labeling, which is kind of relatively evolving imaging technology where you're looking at getting objective measures of brain perfusion, and it allows you to image over stably over a relatively long period of time, and you can look at resting state, which is what Irene and Andy Segadal have done here. And really we're not doing anything to this patient. This patient is just lying in a scanner, and we're comparing those with neuropathic pain and those without, and we are seeing a signal. So we're seeing changes in areas that we know are important in the transmission of sensory information, such as the thalamus, and also areas important with descending pain modulation, such as the periaqueductal grey. So this is interesting that actually we can see an imaging signal which relates to ongoing neuropathic pain. And I think that may well be helpful in the future when you're trying to develop outcome measures in experimental studies for analgesic medications targeted at neuropathic pain. We also see changes when we do apply stimulus. So for instance, this is a patient, these are now where we've applied a thermal stimulus to the feet, and again we've compared those patients with neuropathic pain and those patients without neuropathic pain, and again we're seeing a number of areas of the cortex which had previously been implicated in brain imaging studies relating to pain being more activated in those patients with neuropathic pain. And finally, when we start looking in detail at the structural changes within the brain, and here they've just focused on the insula, as the insula at the moment is a particular area of interest for Irene Tracy's group, and actually we're finding those patients with neuropathic pain an increase in cortical size within the insula. So this, I would say that these structural changes are difficult to interpret, and ideally you would love to have a prospective cohort, but it's very interesting that we're seeing this signal on a structural basis. So just to draw this talk to some conclusions and kind of what have we learned by stratifying patients in this way and trying to compare patients with diabetic neuropathy, but what's special about those that develop neuropathic pain? Well, there is a positive correlation between the presence of neuropathic pain and the severity of their neuropathy. It's undoubtedly true if you can improve glucose control, and ideally we would love to have a disease-modifying therapy for diabetic neuropathy. That may be the best way to prevent or treat their pain, to try and modulate their underlying disease process, as there seems to be a definite relationship with neuropathic pain. When we do quantitative sensory testing, by far the kind of most obvious thing that we see in terms of their sensory profile is reduced sensitivity to multiple different types of sensory stimuli. There is just a very small group of patients that show hypersensitivity to mechanical stimuli such as and display allodynia. We do find a very small proportion of patients that do have gene variants that we know can have an impact on the ion channel function and have been implicated in monogenic pain disorders. These are going to be rare, and at the moment I can't give you, I haven't found any clues to, in terms of the phenotype, where we might be able to pick out those patients for selected sequencing, and ultimately, if specific sodium channel blockers become available to subtypes of sodium channels, ultimately for specific treatments. But clearly that's an interesting idea in terms of personalised medicine. I have shown you some data on imaging, and we can see that there are significant changes in both brain structure and function when we look at those patients with neuropathic pain. And as I said, I think that might be a good substrate for both understanding pathophysiology within the central nervous system, but also as an outcome measure in the future. And finally, what we could really do with would be larger prospective cohorts, because it would be lovely and really, I think, very important to say, if we follow patients at the onset of their diabetes, how can we relate this marked sensory dysfunction to the evolution of their neuropathy? Because that would hopefully tell us much more about what's really driving this process, this important and disabling process within patients. So I'll end there and just say thank you to my laboratory in Oxford, particularly to Andrea Themistokliou and Juan Ramirez, who did a lot of the kind of very detailed sensory phenotyping in these patients. Important collaborators, Andrew Rice at Imperial, Solomon Tesfaye at Sheffield, and my own local collaborator, Irene Tracy and Andy Segadal in Oxford, and the International Diabetic Neuropathy Consortium, which has recently been formed and which I'm collaborating with TROLS. Thank you.
Thank you very much, David. I think we have time for a couple of questions. Again, you can use your app, but you can also go to the microphone and ask questions to David.
Here.
Hi.
Yes, please.
Okay, I don't know whether I'm the first starting. Luis Garcia Larrea, Lyon, France. Thank you very much for this very comprehensive review showing that neither intraepidermal fiber density nor any of the QST different parameters we are able to find out were able to discriminate patients with or without pain in neuropathy. I wonder whether it would be possible for you to add some physiological objective measure of conduction in separately thin fibers and large fibers, like evoked potentials to electrical versus laser or CHEPs, because perhaps by combining these objective measures and the others, you could better discriminate these patients. Is at least the experience in some groups.
Thank you for the question. I'll just say that at a population level, there are some differences between those patients with neuropathic pain and not neuropathic pain, and we did see significant differences. The issue that you may be mentioning is that on a personal individual level, it would be very difficult to pick out a patient with neuropathic pain, unless that patient had allodynia. As I said, that's the one outcome that was absolutely specific to those patients with neuropathic pain. I certainly agree it would be nice to apply electrophysiology, and in fact I didn't go into the details, but we have already done large fibre nerve conduction studies. There is some evidence that there's a slight, and again this probably correlates with the fact that those patients with a moderate to severe neuropathic pain have a more severe neuropathy, and the nerve conduction studies are essentially consistent with that. But we would like to do more. It would be lovely to do more studies of small fibre dysfunction. I guess the ideal thing to do would be microneurography. That's not going to be realistic on this kind of large cohort of patients. One thing that we are just starting to do as a kind of really as an exploratory study is to use excitability testing using threshold tracking as an electrophysiological measure, partly because of my interest in ion channel dysfunction. So I think we're doing exactly as you're suggesting. We are starting to apply more electrophysiological measures to these patients, as I agree that would be a lovely insight into pathophysiology.
Thank you very much. We have a question up there which is about microvascular dysfunction. I think we will take it to the at the end of all presentations, but we won't forget it. So in the interest of time, I think we'll have to say thank you to David, and we will carry on with the next presentation.